Welcome you all to the SSS class. Today is the third session. We'll be dealing with some important topics today, especially from exam point of view. Today's both the topics, burns as well as skin tumors, holds good for long essay as well as short 5 marker. So we will discuss in detail about all the aspects of the topic. And meanwhile, I request all our members to be interactive during the session. I have a lot of questions for you to discuss, so many case scenarios. So I want all your feedbacks spontaneously. Okay, with that, we'll start this today's session. So patient has come to you, 35-year-old lady has come to casualty in this condition, as you can see in the photograph over there. So what do you think? What is the probable cause and how do you go about? Anyone? Can anyone unmute yourself and answer? No, it's not cellulitis. Excellent, Ajay Lakshmi. This is a case of burns. Okay, no history is required as such. Okay, she has even mentioned the approximate body surface area involved also. She's saying 9%. But we all want to know how she calculated, right? And what's the degree of burns here, and what's the etiology of burns? How do we classify these burn injuries? And how do you manage, especially as doctors? Our aim is to manage this case, right? So we'll discuss all this in detail today. So another case, 45-year-old gentleman, when working in a factory, sustained this injury and has presented to you in a peripheral setup. So how do you go about this condition? What do you think is this? Very good. Excellent. Blisters, correct. Second degree superficial, Parth, excellent answer. Correct. That's what I was looking for. Good. So another case, see, similar one. Again, we have a blister here because of the burn scald injury. What about this? Can anyone comment on this photograph? What is this? Excellent. This is a post-burn contracture, one of the complications of a burn injury. So this is a preventable one. So we have to know about this and how to prevent this as well. This is again a question. So today's main topic is burns. We will deal in detail. Okay. So the probable questions from this topic and those who were previously asked in many university question papers. I have shortened them. The only taken the side headings of them, but the questions will be in detail. Mainly, they have asked about us to define the burns injury, mainly to classify them. Okay, what is the basic pathophysiology behind any burn injury? How do any patient present to you? That's clinical features, and further how to manage. They'll give you. This is a favorite question of many examiners because burns is an important topic. When you go to internship next year or being a resident, you should know how to do the first aid or any burn patient for that matter. So they will definitely give a case scenario. 60-year-old gentleman who is weighing 75 kg, sustained 40% burns and presented to your casualty. How do you manage? That's a typical or classical question they ask you in examination. So please be prepared for that. Okay, they have specifically asked management of 40% burns, 50% burns, and 60% burns. And very importantly and very fascinating topic in this particular burns is rule of 9 that we are going to learn today. Wellness rule of 9. And how do we, what are the degrees of burns? What is the first degree, second degree, third degree, fourth degree burns? And very important one is fluid resuscitation in burns. And two separate questions can be asked in this topic, that is electric burns and inhalational burns. Again, important. And as the post-burn sequelae, they can ask you what are the complications of burn injury. The one most important of them is burn contracture. We'll know about that also. Okay, so Any topic we will discuss under 5 headings. This is my rule. Any answer we write in the examination also, we will have a broadly 5 headings. That is, one is introduction or definition, which includes definition, a classification, if any. And second is etiology, causes or any risk factors. Third thing is clinical features, which include both symptoms and signs, and if any complications are there. Fourth is investigations. Fifth is treatment. So we discuss all the topics, major topics under these 5 headings. I'm just repeating so that it gets imprinted in your mind. So what's the definition? A burn is a type of injury to skin or any other internal tissues caused by either heat or even cold, or it could be electrical as well, or because of some acids or alkali chemicals, just because of any friction also, or ionizing radiation. So any injury to skin or other tissues of the body caused by heat, cold, electrical injury, chemical injury due to friction or radiational injury results in burns. Okay, that's the one-line definition you should write. Second thing is, when do they occur? They mainly related to the work environments, okay, where the people are particularly working in, especially ladies sustain burn injuries mainly in the kitchen, okay, scald injuries when they are boiling something, suddenly it's spilled, so they sustain scald injury or flame injuries, or mainly in the industrial area, or even see recently last 2 days we are seeing one in Delhi, one more in Gujarat. Entire the gaming zone was burnt within 30 seconds. Another one in yesterday in on baby care in Delhi, one of the baby care where many infants or neonates were there. Okay, I should not say, I'm very sorry. 6 to 8 babies were immediately got charred within 30 seconds, or 10 of them were just revived somehow. So this can occur anywhere, anyhow. So we can't anticipate beforehand. So we should be well prepared how to prevent and how to go about managing. So this is mainly work. That's why we all seen in our hospitals or even apartments everywhere, there will be a combustible gas combustible that that device will be there. It's because this burns can occur anytime. So we have to be immediately ready to prevent that. So classify, please write along with me how to classify burn injury. Okay, how to classify burn injury. Broadly categorized into, one is thermal injury. Second, very important, is electrical injury. Third is chemical injury. Fourth is cold injury. Fifth is ionizing radiation. These are the 5 major types of burning agents. Again, under thermal or due to any heat, if it's moist heat, we call it as a scald injury. Very important. Many times asked this as a Viva question. What is scald injury? This is because of the moist heat or spillage of any hot liquids. Second thing, by the flames of the fire. Okay. Third is flash because of the any natural gases or spirit, combustible liquids, etc. Fourth is by dry heat, by contacting some objects like hot meals or some heated objects or any materials, we sustain burn injury. That's called contact burn injury. This is related to the heat. Second thing is electrical burns. Very, very important to know. There are some peculiar characteristics here in electrical burns. So we will deal in detail. Electrical injury because getting ourselves in contact with the high voltage current. Okay, that's electrical injury. A spillage of some acids or alkali to our body can cause chemical injuries as well. So we will deal with that. And exposed to severe cold can result in frostbite. That's also kind of burn injury, burns to the skin. So ionizing radiation also can cause damage to the skin or internal organs. That's called ionizing radiation injury. So this is the classification which we will write as a part of our introduction. Okay, very simple. Next, coming to the degrees of burn. This is yet another important aspect of this burn topic. So how do we classify into different degrees? Okay, first degree, second degree, third degree, and fourth degree. First degree burns. First degree burns is when the burn injury is confined only to the epidermis. We know our skin is divided into epidermis and dermis. Okay, so if the burn injury involves only the upper epidermis, then we call it as first degree burns. So what are the characteristic features of first degree burns? It is usually painful because the nerve endings are exposed, okay, from the dermis. So it's painful. It is erythematous and it's blanch on touch. Okay, when we touch that, it gets blanched. The skin gets blanched, and the surrounding skin is hyperemic and erythematous. Best example for first degree is a very mild variety of burns. Best example is sunburns and very mild any spillage of some hot liquids or scald burns that can be categorized into first degree burns. The what we need to know is one what it is. We will write in the first as a first point. Second thing is what are the characteristic feature, that is it is painful, it is erythematous, and it blanches on touching. Third thing, we can give an example. And fourthly, how do they heal? How do we manage and how do the wound heals? That's very important here. Okay, different degrees of burns heal differently. So the first degree burns, they do not result in scarring. They heal on its own with minimal scarring or no scarring at all. And treatment is aimed at comforting with the use of a topical soothing agents. A very small burn injury, just like showed a second photo. You remember in the hand there was a small blister. Was actually it's a second degree, but just imagine like that. This small area of burn is there, so nothing to be done. It will heal on its own within a week, without any scarring. So you give us topical soothing agent so that there will be no that burning sensation or any pain in that area. Okay, that's the management of. And you can give a very minimal paracetamol or any anti-inflammatory drug so that it doesn't progress or doesn't cause any pain to the patient. Coming to second degree burns. In second degree, which you already mentioned in your answers, it can be further divided into two types. One is superficial, second is deep. Okay, if it is involve the epidermis and upper part of the dermis, what is that? Papillary dermis. Correct? We in the skin there is two layers. This epidermis, and in the dermis there is upper papillary and lower reticular. Correct? So if the burn injury involves the epidermis and the papillary dermis, then we call it as superficial second degree. If it is involved the reticular also, then we call second degree deep burns. Hope it's clear. Okay, we'll again revise that. Here the characteristic feature is it's again erythematous because hyperemic because of the vasodilatation, and it again painful because again dermis is exposed, the nerve endings are exposed, it's getting irritated, so it's painful and blanches on touch. Okay, the characteristic feature here is blisters. Often they form blisters. Second degree superficial burns result in blisters. Okay, because epidermis is fully gone. Okay, so it get thinned out and cause blisters. Example is scald injuries from overheated water or flash from the burns. Here also wounds re-epithelize on their own. Okay, within 1 to 2 weeks. First degree was within 1 week. Here 1 to 2 weeks may cause slight depigmentation, hypopigmentation. It can cause slight hypopigmentation. It can cause. Whereas deep dermal burns, okay, they involve the reticular dermis as well. They appear more pale and mottled. Mottled means, crumpled. The paper, if you take a paper and crumple it, how it forms. Similar, the skin also get mottled, mottling of skin. They do not blanch on touch, okay, because all the vessels, everything is destroyed. It only when deep prick, if you prick with a pin, it may cause little bit pain, not otherwise. Heal within 2 to 5 weeks by re-epithelialization, causing severe scarring. Remember, first degree, no scarring. Second degree, superficial, minimal scarring, whereas deep burns will cause severe scarring. Third degree burns, here the entire skin and subcutaneous tissue also involved. Okay, so full thickness through epidermis and dermis. Okay, here the characteristic feature, the third degree burns. When do you say that it's third degree burn? Just by looking at it, you can tell it's a third degree burn. What is the feature here? In many MCQs or anywhere in the case scenarios, they'll particularly mention that, but particularly one word. Okay, what is that? It is eschar formation. Okay, that means it's a very deep burns. Eschar formation. Okay, then it's nothing. Eschar is nothing but a very hard and leathery type. The entire thing gets charred. Okay, then it's called eschar. So this characteristically painless, entire nerve, everything is damaged, completely damaged. So it's painless and completely blackened. It's charred out. That's third degree burns. It is a deep dermal and full thickness burns require excision of the eschar because it acts as a tourniquet sometimes. If there is a circumferential eschar is there, it acts as a, it tightens the underlying limb or any organ. So it acts as a tourniquet because eschar is a charred tissue. If it becomes like this, the underlying blood supply may be hampered. So immediately you have to act. Any intern or any resident also will become a surgeon and immediately do the escharotomy or excision of that particular eschar blackened area, so that area gets released. So blood underlying blood supply, whatever jeopardized, it will get reconnected. Okay, so that's a treatment. Immediate treatment is escharotomy. Okay, so requires excision of eschar. And if a large surface is involved, you can cover it with skin grafting. If a small eschar is there, you can it will heal by secondary intention. Clear? So what is 4th degree burns? If the underlying organs or any fascia, tendons, muscles, bones involved, then we call 4th degree burns. So now again to revise, what is 1st degree? Can anyone revise along with me? Who is there? Can anyone revise along with me? Unmute yourself and revise with me.
So, 1st degree burn is confined only to the epidermis. The second degree is further divided into superficial and deep. So in superficial, it is confined to epidermis plus papillary dermis, and deep is confined to epidermis plus reticular dermis.
Perfect.
In 3rd degree burn, we have epidermis, epidermis and dermis,
and
subcutaneous tissue also.
Right, yeah.
And 4th degree, we have involvement of organs, fascia, and tendons.
Underlying structures. Okay, like any tendon, muscles. Akshita, can I ask you one question? How do you
yes, sir.
Say it's 3rd degree burns? What is the characteristic feature?
Sir, eschar formation is there.
Formation. How do you say it's a 2nd degree superficial?
Sir, there will blister formation plus erythema.
Yes, how do you say it's a 2nd degree deep?
Sir, there will be blister formation plus pinprick pain will be there, and
it doesn't blanch on touching.
It doesn't blanch. Yes.
Okay. So hope it's clear. Very important. Classification. We have classification of burns important. Degrees of burns. Each one is a question. See, I have not included even a single point which is not relevant to you. I'm not going to give any extra knowledge to you. Whichever important for exam sake or some to know, must know concepts are there as a maybe for your future practice or for exam. Only that much I'll be discussing here. Other than very vast information is available, may not be relevant or required at this moment. Okay, so coming to the pathophysiology. Pathophysiology, what are the changes occurs, when a patient suffers burn injury? What are the local changes? What are the systemic changes? We will classify and tell. We can write it system-wise also to different systems. How do they affect? What is local? This is again another question asked. Okay, at locally, you describe local changes by a concept called Jackson's zones of burns. Jackson's, write along with me. Jackson's zones of burns. There are 3 zones. First one is the innermost zone. That is zone of coagulation. The middle one is the zone of stasis. Okay. And the third one is the outermost one. That is the zone of hyperemia. This is the third one. The zone of hyperemia. So first one, the innermost one is the zone of coagulative necrosis. Okay. And the middle one. So this is the middle one. Sorry, innermost. Okay, innermost is the, I'll show you with the figure. Okay. So this is the one. This is the one. Zone of the innermost. You have zone of coagulation, coagulative necrosis. Okay, that's gone already. The entire tissue is already necrosed and dead. You can't change it at any way. It's gone. It has to be replaced. Second, the middle one. Middle one is the 50-50 one. That is zone of stasis. There is already vasoconstriction has occurred. So blood supply is not there at present. If we immediately intervene, it can the blood supply can resume and it may become viable. For now, it is hypoperfuse. So it's at a stage of 50-50. So that is zone of stasis. The outermost one is the zone of hyperemia, where the cutaneous vasodilation occurs and there is a perfusion is there, hyperemia. This is the one which is salvage, already not in danger, we can say. The middle one can be salvaged by timely intervention. So these are the three zones of Jackson at the site of, at the local area of burn injury. This is one again 3-marker asked, which are the zones of burn injury or Jackson's zones. It can be a question again like that. Okay. Coming to the burn area assessment. Again, this is a very interesting and important one. How do we calculate? In Jayalakshmi told in the initial the question only that the patient has in the arm, she has sustained 9% burns. How did you tell that, Jayashree? How could you tell that? It's 9%.
So the limb, the lower limb is 9% in
There's
the
a rule of 9, as stated by who was given that the rule, you know,
Wallace.
Wallace rule of 9. Okay, we will remember. Okay, Wallace rule of 9. So all of you, please be with me. You all know this, but still we will revise. There are sometimes confusion. So please be with me. You also act along with me and act along with me. Say for adult, entire head and neck constitutes how much percentage of body surface area? 9%. Entire head and neck. Entire right hand is 9%. Entire left upper limb is 9%. The upper chest is 9%. The upper back is 9%. My abdomen constitutes the lower, this thing is 9% and lower back is 9%. My front of the lower limb, entire lower limb constitutes 9% and back of the lower limb constitutes 9%. Same on right side and left side. So it's totally how much now? 11. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 parts. So 11 into 9 is 99%. 1% is remaining. What is that? Genitals. Very good, Shankar Narayan. It's a perineum and genital region constitutes 1%. So this is when there is a cross burns present. If there is a very discrete here and there, some burn area is there, then how do we calculate? Small burns on here, little bit burns in my chest, little bit burns, burn injury is there. Then how do we calculate the percentage? Yes, Fatima is right. She says it's a rule of palm. See, entire hand, entire palm, the open palm along with the fingers. This constitutes 1%, not my hand, but whose palm? It's patient's own palm. Okay, patient's own palm. You ask the patient to open up his palm and take a paper and measure it. Okay, take a paper and cut it to that size. That constitutes 1%. Now you can calculate, keeping that paper cut piece over any burn injury. You can see how much percentage of burns is present. Okay, so you can calculate 5%, 6%, whatever the percentage you can calculate. So once again, to revise for those who doesn't know, or even some third years also there with us. So rule of 9 by Wallace to calculate the body surface area, total body surface area of the burn injury. Head and neck constitutes 9%. I have a photo here for you. Okay, the front and back of the entire head and neck constitutes 9%. The chest is 9% and abdomen is 9%. My right upper limb 9%, left upper limb 9%. Okay, front of right lower limb 9%, back of right lower limb is 9%, front of left lower limb 9%, back of left lower limb is 9%. So it's 99% and 1% is perineum and genital region. Okay, and it's slightly different in children, usually not asked, but you better know it. In the children, as you know, what the difference is, the head and neck is bigger. Head is bigger than the body. The limbs are smaller comparatively. So head and neck given the double the proportion, that is 18%. The rest all remains the same, whereas the lower limb is slightly lesser. Instead of 18-18, it's made 14-14. Remember, that's the only difference. And here, not 1% separately not given to the genital region. Okay, it's very small. So only difference is in the head and neck. Instead of in adults, it was 9%. Here it is 18%. And the limbs, each limb, lower limb was 18% in adults, whereas in the children it is 14%. That's the only the difference we should know. Okay, and 2 questions for MCQ for the entrance exam. They can ask you 2 questions. Which is the easy, simple one, preferred way of this thing calculation is Well's rule of 9. But there are more specific one. Lund and Browder's charts are available. They're very specific area wise. They're the most specific. If they ask which is the most specific and preferred one, Lund and Browder's. Whereas which is easy, convenient, and simple to use is Well's rule of 9. Okay, that's the 2 things you should know. Coming to the systemic changes occur in any burn injury. When a patient sustains a severe burn injury, there are so many metabolic changes or hemodynamic instability changes occur in our body. Most importantly, the first one is the permeability of the vascular system is increased. Okay, there is the capillaries they leak. So all the intravascular volume, they go into the extravascular compartment, interstitial compartment, resulting in what's called edema. Edema is the main problem because of the leaky capillaries, because of the increased capillary permeability. Okay, that's the first change. Okay, I'm telling you, this is a point-wise you can write. See, if you write one flow chart like this, it's self-explanatory. You need not have to write paragraphs. For a 10-marker question, 1 paragraph like this depicting the systemic changes more than enough. You need not have to write pages and pages or paragraph together. Second thing is hemodynamics. What happens? Okay, what happens? Anyone? What happens to the hemodynamics? What happens to the cardiac output? Because a lot of volume is lost. Okay, because of the dehydration or even because of the loss of plasma, lot of fluid is lost. So hypovolemia, it results in hypovolemia. So decreased cardiac output can result in shock, hypovolemic shock. Patient may go into very good path. Patient may go into low cardiac output state or also known as hypovolemic shock. That's the hemodynamic instability. Third thing, patient may go into hypermetabolic state because it's actually catabolic state. Everything is getting lost. Okay, glycogenolysis, proteolysis, everything is lipolysis, everything is happening. So they may go into state of increased BMI, hypermetabolic state, because it's a emergency state in the body. All the hormones, everything will secrete, and emergency hormones will secrete, and they result in hypermetabolic state. And because of the internal injuries, it can result in the blood supply is altered, ischemia, result in internal body damage also. If it is involved the GI system, that can result in the mucosal atrophy. Mucosal atrophy can result in what's called, the simple question asked there, Viva question, what is that? What is the ulcer we get in stomach because of burn injury? Yes, Curling's ulcer, very good. Curling's ulcer. What is Cushing's ulcer? Cushing's ulcer, we get in increased, yes, in head injury, intracranial tension. Okay, that's called Cushing. Don't get confused. Cushing's triad, Cushing's reflex, everything is related to the brain. So in brain injury, you get Cushing's ulcer, whereas in stomach, in burn injury, you get Curling's ulcer. Okay, so if the blood supply is further jeopardized, that can result to decreased renal blood flow. Okay, so that can result in acute kidney injury, and most importantly, patient will go into state of immunosuppression, because the entire covering organ of our body, skin, is gone. So we are prone to all kind of losses from inside the body, and we are prone for all the invasion from outside the body. All the bacteria, protozoa, everything will invade. So it's a state of immunosuppression, and we can it's a the patient is prone for secondary infections. Okay, these are the systemic changes which can occur in a burn injury. To go, so hypermetabolic, some important ones, or they can particularly ask a question: what are the metabolic changes in a burn injury? So I have like any metabolic changes in any injury. Here also, it has two phases. First thing is F phase. Any response to metabolic injuries, we have two phases: F phase and flow phase. F phase is initial 1 to 2 days. F phase. Okay. Here, what happens is there is a, just like I mentioned, there is a decreased cardiac output because of hypovolemia, increased oxygen consumption, increased oxygen demand and oxygen consumption. Metabolic rate is increased, hypermetabolic rate. Okay. And the glucose tolerance is impaired. Okay. So because of the decreased insulin secretion and because of stress, there is a gluconeogenesis is also increased. That's why it impaired glucose tolerance, which will result in hyperglycemia, state of hyperglycemia. Okay. This is in the initial 2 days, in the F phase. Subsequently, in the flow phase, 3rd to 5, 6, 7 days, there is slowly everything starts settling down. Okay. Metabolic, what are the requirements are there? Variables, whatever have been gone down, they start slowly increasing. Okay. Hyperdynamic circulation ensures, and initially whatever the metabolic rate was gone down, now it will be hypermetabolic state. Okay, initially there was hypometabolism, patient was not taking any, it's a catabolic state. Initially it was catabolic, slowly it will turn into anabolic state. Okay, so these are the, just like any, this question is usually not asked. If asked, just like any response to any metabolic injury, in burn injury also, it contains F phase and flow phase. Initially catabolic state, then slowly they recovers by anabolic phase. This you can write in 2 lines. Inflammation and edema, just like mentioned, massive release of all the inflammatory mediators result in increased capillary permeability and leaky capillaries. They result in the movement of the intravascular fluid into the interstitial space, leading to edema. Renal system, diminished blood flow and cardiac output, and also along with that, there is a lot of stress-induced hormone secretions like angiotensin, aldosterone, vasopressin, etc. Okay, though this result in further decrease in the blood flow to the kidney, hence decreasing the GFR. So if the GFR comes down, it will result in initially oliguria. If timely intervention not taken, then anuria, acute tubular necrosis, and renal failure can be there. Okay. Most important, remember, they'll ask which is the first system to involve in burn injuries. It's the first in this thing involved. Anyone? It's the first system get affected. Anyone? Any idea? No, not actually. No, not circulatory. No. The first thing is the respiratory, second thing is the renal. Okay. So these are the 2 systems. Effects on GI system, I already told it can result in mucosal atrophy, and the digestive capacity is reduced, and intestinal permeability is increased. So finally, what you should know here is it results in Curling's ulcer. That's all. Immune system, there's global depression of the immune function. Okay, there is a great risk for all the secondary infections, including bacterial infection, fungal, viral infections. Okay, all this because of the activation of the immune mediators like neutrophils, macrophages, and T lymphocytes. Okay, now we have some questions. Okay, now we have through questions we will solve. Okay, solve the concepts. So please read this question. This is a PGI type of question. Okay, please try to answer. Which of the following statements regarding respiratory problems in burns are true? This is very logical and requires only common sense. So you can try to answer. Burn injury to this function may be lethal. Respiratory system. Okay. Injury can be due to inhalation of hot or poisonous gases. Burn injury is more common in the supraglottic than in the lower airway. Hemoglobin combines with the carbon monoxide less easily than with oxygen. Hydrogen cyanide interferes with the mitochondrial respiration. So what do you think is the answer? Which of the following statements are true? Jayalakshmi is telling ABC. Vasishta is telling D is false. So, but none of them is correct. I mean, none of them is complete. You are right. You are right. But none of them is complete. Ezil Rasi is telling B and C are right. Can anyone give a complete answer? The first one, burn injury to this function may be lethal. Is it not? It's not. Is it not lethal? Yes, of course, it's lethal. Injury can be due to inhalation of hot or poisonous gases. That's correct. Okay. Burn injury is more common in the supraglottic than in the lower. No. It's inhalational burn. They enter into mainly into the lower airway than the upper airway. Okay. So C is wrong. Hemoglobin combines with carbon monoxide less easily. No, more easily. They have high affinity, 240 times higher than the oxygen. Okay, so carbon monoxide readily mixes with the hemoglobin, and hydrogen cyanide definitely interferes. You know that cyanide poisoning, which enzyme it interferes, everything, you know, forensic you learned. So answer is A, B, and E. Okay, A, B, E. Sorry, this thing. Okay, supraglottic is more common. Inhalation supraglottic more common. Less common if it is very severe. They stay for longer duration in the space. It can result into the lower lower airway. So initially it affects the upper airway. Okay, so the answer is A, B, and D. Bones can damage the airway and lungs, which is life-threatening. Burn injury is more common in the lower airway than in the supraglottic airway. Okay, carbon monoxide has an affinity 240 times more greater than the oxygen for combining with hemoglobin, thus blocks the transport of oxygen. And hydrogen, this is a question for you again. Hydrogen cyanide is a metabolic toxin produced by house fires which interferes with the mitochondrial respiration. Which enzyme? Anyone can say? Can anyone say which cyanide affects which enzyme? Please answer. Very good, Fatima. Cytochrome oxidase. Excellent. Cytochrome oxidase. Okay. In surgery, we don't write all those things, but better to know. Okay, for at least for entrance point of view. Another question for you. Which of the following statements regarding smoke inhalation is true? Smoke inhalation are true. Again, PGA type of question. Please try to answer. Inhaled smoke particles can cause a chemical alveolitis and subsequent increased gaseous exchange. Inhaled smoke particles may be suspected with a specific situation in an enclosed space. Early elective intubation is contraindicated. Symptoms can take 24 hours up to 5 days to develop. The result of carbon monoxide poisoning is a metabolic alkalosis, best treated by low inspired oxygen. So which you think is are the true among one A, B, C, D, E? Shankar Narayan is telling B. Akshita is telling B and D. What is B? Inhaled smoke particles may be suspected with a specific situation in the air. That's correct. Anyway, I agree with you. B is correct. Radhika is also the B and D. So yes, you're all right. B and D. Okay, answer is B and D. Correct. Excellent. So this question I gave particularly, you have to read the complete answers, complete options, because first half will be sometimes right, second half will be wrong. Okay, so this is the best example for that. Inhaled smoke particles can cause chemical alveolitis. That's correct. When we just look at that and we feel it's correct and we think it's we take it right. But look at the second part and subsequent increased gaseous exchange. No. That part is totally damaged, so result in decreased gaseous exchange. That should be the answer. So that's wrong. Okay, if you read completely, you will get it right. Inhaled smoke particles, that's correct. Early elective intubation is not contraindicated. In fact, it's indicated because once the laryngeal edema starts occurring, then it will be very difficult to intubate. Then we may have to go into cricothyroidotomy or tracheostomy. So it's better to intubate in the early phase when we suspect some inhalational injury. So this is again wrong. This option is wrong. This is correct. Symptoms can take up to 3 or to 5 days. It may not be very evident initially. Slowly, edema will increase and cause suddenly stridor or respiratory distress. That time it would be very difficult to intubate and all. So it's better anticipate in any inhalation injury burns patient, anticipate that they may go into respiratory distress and electively intubate, ventilate, and once the edema and all subsides, then you can take them out of ventilator. Fifth one is the result of carbon monoxide poisoning is a metabolic, not alkalosis, but metabolic acidosis. How metabolic acidosis? Can anyone say? Carbon monoxide poison results in metabolic acidosis. Anyone? Simple, one word answer. CO2, lactate. Yeah, how lactate? Correct. You're right. Give me before one word before that. This is a flow chart. You're right. One. Yes. No, anaerobic metabolism. Why anaerobic metabolism? Okay, you're right. Anyway, so carbon monoxide is not effective in doesn't carry oxygen. Very good. So hypoxia. Hypoxia result in anaerobic metabolism, lactate production. So metabolic acidosis. So hope it's so. You should be very clear with the concepts. All carbon monoxide. Carbon monoxide means CO2 retention or respiratory acidosis. So it may cause compensatory metabolic alkalosis. That we may think like that. That's wrong. Okay, so the concept should be clear. So coming to the, now we know how to assess the burn injury and how to calculate the burn injury. What are the different types of burn injury we know. Now, how do we immediately care if it occurs nearby your house or nearby your school, college, anywhere? What do we do immediately? First and foremost is the stop the burning process. Make him roll over the ground or put some blanket over him. Do something or importantly take off all his clothes. That's very important. Okay, so somehow stop the burning process. That's a very important. Immediately, as even layman can check for the ABCs. Okay, or even a medical professional, you can check for immediately the patient's ABCs. Okay, vitals, airway, check for airway whether it's patent or not, whether it's breathing normally or not, and check for the pulse and whether the circulation is adequate or not. Check for all these things and immediately do the secondary survey. Look for any life-threatening injuries are there. Okay, maybe he caught fire in the 7th floor and suddenly jumped from there and sustained a neck injury, which is cervical injury, which is life-threatening. Okay, while transporting and also do the ABC and immediate secondary survey to rule out any life-threatening condition. And if it's still burning, the skin is everything burning, immediately make him sit under a running tap water. Okay, for about 20 minutes or so. White running tap water. Why not ice cold water? To avoid hypothermia. Hypothermia again dreaded. Okay, so under running warm tap water, make him sit for 15-20 minutes. So that will give a lot of comfort. The pain that whatever that burning sensation is there, that will go away with that. Okay, so that's very important even before starting any other treatments. And if he is having inhalation injury, if he has sustained burns in a closed space and all, you can give a supplemental oxygen also. If you think is having altered consciousness because of the this thing CO2 narcosis. Okay, when brought to the hospital, again check for the ABCDEF. If for airway control is very important, especially in the inhalation injury. Okay, second thing is breathing and ventilation. Just like any trauma ATLS protocol, check put a wide bore cannula and start the fluids to maintain the circulation. And disability, any neurological status you check for, and any like expose him completely and check for any other secondary injuries are there. And very important, burns, particularly burns. What's more important here is, yes, that is fluid resuscitation. Okay, fluid resuscitation will deal in detail. So major determinants of the outcome of a burn are percentage of burns, the body surface area involved. More the percentage of body area involved, the outcome is not good. Depth of the burns. If the burns is 3rd degree, 4th degree, the outcome is not that good. Okay. The presence of inhalation injury, because for inhalation injury, you can't do anything. Already the soot particles or the flames have gone inside and burnt everything. The lungs once gone, you can't do anything about that. Okay, whatever cleaning, whatever ventilator will not help. So that's a very dangerous one to get. That is inhalation injury. Okay, this is the scenario. Already secured airway, breathing, everything. Okay, airway. How do we know the airway is affected? What are the clinical features? Patient will have a husky voice. The strider. This husky voice will be there because of the larynx have got edema. Because of edema, he cannot utter properly. He'll be anxious, very much agitated and anxious, and the respiratory breathing pattern will be slightly different, and he will be slightly disoriented. It all shows that yes. Other what are the things which suggest that he's suffered inhalation injury are this again a question. Soot particles in his sputum. Okay, singed hairs. His nostril hairs will be singed because of the burn injury. Okay, and there will be in the posterior pharyngeal wall also you can see the soot particles. Okay, when he asks the patient to cough out the sputum, it can contain soot particles. And of course, the history of sustaining burn injury in a closed space with gases or fumes. All these are suggestive of inhalation injury. In that, you have to suspect airway injury and anticipate laryngeal edema and be well prepared to intubate. No, this our hydrocortisone, all those things will not help. Only elective intubation, early intubation is the only key. Breathing, okay, same thing, okay. Initial, if in the initial phase, they'll have a difficulty in breathing. You can give supplemental oxygen. Some chest physiotherapy can be done. Nebulization can be done, and humidified oxygen can be given. If it is severe burns, then you can put him on the patient on the ventilator and can give continuous or intermittent positive pressure with either with a mask or TPs. If it is very severe, okay, burn, entire thing is burned, chest and neck area or even the face, then better to do the intubation at the earliest. Okay, these are not important. I'll just skip. I'll go a little faster when it's not important. Okay. Important concepts, definitely I'll deal in detail and clearly. Any doubts you can ask. Here, the most important, if I am the examiner, okay, in the burns, I'll ask only 2 questions to you. If I'm the examiner. One is, that is rule of 9. How do you, when the patient has come to you, how do you calculate the percentage of burns? That would be my first question. Second is this fluid resuscitation. How do you initially manage the patient? That will be my, because as a UG at the level of undergraduate, these are the important things. If you, how much ever you know the pathophysiology or this, that, it will not beneficial in an emergency. In emergency, what really matters is when the patient has come, suddenly everything is like a big havoc has been created. Immediately, how do you act? So immediately stop the burning process and make the patient cool under the running water. Clean the wounds, immediately clean the wound and start the fluids. Okay, calculate the percentage of burns accordingly. Start the fluids. Now we'll know how to do the fluid resuscitation. Okay, because why fluid so important? Because in burns, nothing more than anything, the internal plasma is lost, the maximum. That's most affected. So if the plasma is lost, it will result in hypovolemia, and it can go into immediate shock and you can die immediately. So you have to replenish that lost fluids. That's why this is important. So when the fluid resuscitation is indicated, that may be asked question for any child with a burns percent greater than 10%, or for adult more than 15%, intravenous fluid resuscitation is indicated. The famous formula what's used here is Parkland's formula. Parkland's formula. Please know this in detail. Parkland formula, one question definite, 100%. Okay. Calculate the fluid to be replaced in the first 24 hours by the following formula. Please write, even if you know, please write along with me. That is 4 into body weight, patient's body weight into total body surface area of burns. Okay. When you multiply this, you get a number. That is the amount of fluid to be infused over one day. How do we give? the entire amount is first half. If for example, if you get 2000 ml, that means 2 liters. 2 liters of total amount of fluid to be infused in one day, 24 hours. So first half, that is 1 liter to be infused in first initial 8 hours, means little more is required in the initial phase. And remaining 1 liter to be infused in another 16 hours. So total 24 hours, you will give 2 liters. Now to make it more clear, I'll give you a case scenario for you. 60-year-old male, please write along with me. I'll give the case scenario. 60-year-old male. Okay. When he was cooking, okay, if his wife was not there at home, so he was first time he was started cooking. Okay, when he was boiling rice or something, the cooker got blasted and he sustained a major burn injury. Okay, including his burn injury involves and full head and neck, left lower limb, okay, and upper back. I'll answer to that, Jayalakshmi. Okay, you're a good question. Okay, so 60-year-old male, remember, 60-year-old male, when cooking, sustain burn injury to head and neck, left lower limb, and the upper back. Okay, now calculate how much fluid to be given to this patient. Only intelligent my students will answer. Fatima, 6480 ml. Fatima, she's very good in mathematics. Yes. Yes, this is what I was expecting. Jyotika and Meenakshi are right. All are busy calculating, but nobody noticed that what's not there, what I have not mentioned. You got confused with what intentionally I was deviating you. I had given you the age, but what is required here is weight. I have not mentioned the body weight here. You should have asked that first. Sir, what is the body weight? You took the age as the body weight and calculated. Am I right? So see, these are the common things what mistakes we do. We think we have after the coming out of the exam, we think that we have done everything correctly or perfectly. But these are the small it should be, means these are not mistake. You know it perfectly, right? You know the formula very well, everything you know. But being bit casual while reading the question or taking everything, Parklanda, what is there in that? Taking things lightly. This attitude not good for doctors, at least. Everything, even small wound also, I'll show you when we deal with electrical injuries, I'll show you. Even a small half centimeter wound can kill you. So you should, from now only, you should change your personality so that everything you take very seriously and attentively. Okay. In your during your dissection times, your teachers would have told you observation is the key to become a successful doctor. Correct? So what you required here is weight. Okay, weight. So weight, you say, which is simple for your calculation, 50 kg. 60-year-old male weighing 50 kg. Now calculate. $3,200. Even I have to calculate now. Even I don't know. So first you have to know what is the body surface area. 4 into weight is I have given already 50 into body surface area. What is the body surface area involved? Head and neck constitutes. I made it very simple for you. 9. Left lower limb completely it's 18%. Complete left lower limb is 18%. So 18, 27, and upper back is 9%. So total 36%. Okay. So 50 into 4, 200. Okay, 200 into 36. How much I don't know. You tell me. 200 into 36. 7,200. Okay. 7,200 is the right answer. Now, how much you give? 7,200 or 7.2 liters has to be given. 7.2 liters will not cause any Jayalakshmi. Okay. This is okay. 7.2 liters, okay. In this, 3.6 liters. 3.6, no? 7.2. Oh, yeah, 3.6 liters, correct. Will be given in first 8 hours, and remaining 3.6 liters will be given in another 16 hours. So, Jayalakshmi was right. What if, sir, it's 90% burns? She asked. No, then how much it will be? 4 into 50 into 90. How much it is? 200 into 90. It is 18,000, 18 liters. If you give 18 liters, you are killing the patient. Not by burns, but patient will be died because of your fluid overload. It will cause pulmonary edema and patient will die. Okay. So here the trick here is you will calculate for maximum of 50% burns, 50% body surface area. If it is 55% burns there, you calculate for 50. If it is 45, you calculate for 45. You understood now? The maximum body surface area which can be counted for calculation in Parkland formula is 50%. Remember that. Is it clear now, Jayalakshmi? Hope your doubt is clear. That's what you doubt you had now. How can you give 18,000 like ml of or 18 liters fluids in a day? That was your doubt, right? Okay. So monitoring of resuscitation. That's about Parkland formula. There are so many other formulas are there, but this one you remember more than enough. Okay. Monitoring the resuscitation. The key to monitoring resuscitation is urine output. See, each point is a question for you, please. Okay. Remember urine output. Urine output should be, what is the normal urine output is for anyone? 0.5 to 1 ml per kg body weight per hour. 0.5 to 1 ml per kg per hour is the normal output. That much should be there. If it's decreased, then you have to, it means that lot more fluid is required. So how much to give? 10 ml per kg bolus. If you are 50 kg, then 500 ml, one bottle full of normal saline or ringer lactate, you give bolus immediately. Even then, if it doesn't involve this thing, then you have to start some inotropes and all. Okay, so that's the that's how you manage. Main thing what you at this point you should remember is how do you monitor the fluid resuscitation is by hourly urine output. Okay, okay. Very important is patient should not be over resuscitated. What are other points in management of burns is analgesia. Adequate analgesia should be given by opioids or paracetamol. Best thing is to give some sedative, so that they'll sleep off, they'll not feel the pain. So there's a thing. Many dressings and all done under general anesthesia for burn patient, especially the kids. Second thing is energy balance and nutrition. There are so many formulas to calculate how much calories to be given. There is a formula not required for you. 25 into kilocalories plus 4 into how many, so many formulas are there not required. And proteins, 2 grams into per kg, 2 grams of protein should be given. So all those things. Next, mainly infection control. These, as I told you, they are prone for all the secondary infections. So this has to be prevented by isolating the patient, giving proper ventilation and other things, and proper covering of the wounds. So that because they are prone for all the nosocomial infections. Most common ones are Staphylococcus, Streptococcus, and Pseudomonas. Most commonly Pseudomonas infection. Okay, notorious in burns patients. So proper nursing care of the wounds, everything. Physiotherapy to prevent bone contracture. Proper physiotherapy start initiate from the beginning itself, and more very importantly the psychological support, the moral support has to be given. Okay, coming to the treating the burn wounds. Okay, for as a surgical point of view, you have escherotomy. It's the 3rd degree. See, these are all the blackened ones. These are all the eschars. What are the black portion? What you can see here. See, these are all the eschars. I already done the escherotomy. See, this is the escherotomy wound. Can you see on the either side? The skin has been, it was circumferential eschar. Circumferential eschar was tightened the entire limb. Okay, so blood circulation was hampered. So we put a one axial, one cut from the thigh to the toes, so that the compartment is released. The tight tourniquet is released, so that the underneath the vessels can be free to circulate the blood. Okay, that's called escherotomy. Okay, coming to the electrical burns. electrical burns, you need to know when you're 4 to 5 points. It can be a 5 marker or 3 marker. 5 points, I'll tell you. Any 5 marker, you know 5 points. For 10 marker, you know 10 key words. That's more than enough. If you write 10 key words for the 10 marker, you get maximum marks. For electrical burns, 5 points. First thing, it can be classified into low voltage or high voltage injuries. Okay. If it's more than 1000 volts, then you call high voltage injury. If it's less than 1000 volts, then you call low voltage electrical injury. High voltage and okay, that's the first point. Okay. So here the problem is the flash, what the current flash is there, it will ignite the clothes and cause a flame burn. That's the one thing. Sometimes when we catch hold of the current wires and all, in forensic also we have learned that what's peculiar about the electrical wound, electrical injuries, there will be two wounds. One is entry wound, another one is exit wound. Patient failed to notice the exit wound. He will only come with only the entry wound. See, there is a one injury in my palm. But as a doctor, it's your duty to look for the, if it's electrical burn means there should be an exit wound. So you look for in the sole or somewhere, there is exit wound which are in contact with the ground. You check for any exit wound. So you have to treat both. Many very severe injury, any electrical injury, severe injury, deep injuries, it can cause all the fractures and convulsions. What's the most important dreaded is it can kill you immediately. It can kill the patient immediately by interfering with the electrical impulses of the heart. See, this is one electric current. In your heart, already there is one electrical current passing, right? Correct? So this current can interfere with our heart's electrical impulses, then can cause what's called ventricular fibrillation, and patients died immediately. So if you are intern, now tell me, if you are intern, a patient comes with electrical injury, what is the first thing you will do? I'll give you options. Cleaning of the wound, calculation of the percentage of burns, fluid resuscitation, ECG. Yes, correct. Okay. First thing, you can just by palpating the pulse also, you'll come to know whether there is any fibrillation, anything is there. Or best way to record it is ECG. So any electrical injury, the most life-threatening is VF. Okay, that's the first thing you will do. Second thing is here volume research. It's a fluid resuscitation also very, very important. Why? Because of the contraction of all the muscles and all, many muscles will die. Even the myocardium also will die. Patient may die because of the myocardial injury, not just the electrical interference. If the muscles die, they release what's called myoglobin. Okay. What myoglobin will cause? Myoglobinuria. If it goes and deposits in the kidney, that will cause AKI. Okay, renal dysfunction. Patient may, correct path. It can result in rhabdomyolysis, myoglobinuria, AKI, renal failure. So this is the second complication. One is VF, second is renal dysfunction. Second complication of electrical injury. Okay, these are 3-4 things you should know. Okay, in electrical injuries, chemical injuries. Okay, chemical injuries, it could be both acid or even alkalis also can cause injuries. Not very important, just know it can cause 2 types of injuries. One is if it's spilled over your tissue, it can destroy the tissue. That's one. Second thing, it can get out of the chemicals that can be absorbed into your bloodstream or any other underlying tissue, and it can cause toxicity. Okay, it can cause poisoning or toxicity. So 2 types of effects by chemical injury. That's why if a examiner has asked you question on chemical injury, means he's expecting you these 2 points. Not only the physical injury, but also chemical injuries will result by toxicity. If it gets systemically absorbed, it can result in poisoning, some things. Okay, so only treatment for this is lavage, copious lavage with water. No use of neutralizing agents or some antidotes and all. Okay, so first thing is lavage. You give thorough lavage. Second thing is identify which is the chemical. Okay, chemical. Then you can treat accordingly. One example I will give you, which is the most common in industrial area, which occurs chemical injury, that is hydrofluoric acid. common chemical injuries, hydrofluoric acid. It's a very mild acid. Okay. What is the problem with this is it will cause you, wherever spills, it resorb the bone and cause hypocalcemia, which is again life-threatening. Hypocalcemia, it will result in hypocalcemia. Yeah. It's possible, Swati. Toxemia possible in acid injuries, I'm telling you. Hypocalcemia, it will result. Okay. So it's hypocalcemia is again not good for heart. So what is immediate treatment is 2% calcium gluconate. Okay. It's in the form of gel you can apply. So, okay. So the hydrofluoric acid, the treatment is calcium gluconate. Remember that much enough. Okay. That's about, so 3 things in burns. Okay. One is burns classification you should know, and degrees of burns, first, second, third, fourth, and how the characteristic features. 4th thing is Well's rule of 9. Okay. And Parkland formula. These are the very important. All this pathophysiology, clinical features, and all you don't worry. Okay. And then other 2 which can be asked are, one is electrical injury, one is inhalation injury. Or inhalation injury mainly asked as a MCQ, not in the theory. In the theory, sometimes chemical injury can be asked. Okay. Just to know that, not just the local injury, but it can also result in systemic effects as well. That's about the burns topic. The device. Okay. So acute tubular necrosis can occur in burns due to following factors except toxins, myoglobin, aldosterone, and hypovolemia. Come on, all of you answer. Answer is aldosterone. Simple one. Okay. Adequacy of fluid resuscitation in burns is assessed by. These are mainly questions for your final year exams. Okay. There will be 10 MCQs. No, these kind. Okay. Urine. See, all the 4 options I have got urine. That's why. See, if you know the half answer also, it's difficult because all the 4 options have got urine. Then which is the most appropriate one? Yes. This question shows us the importance of knowing the answer completely, not just superficially. If you just knew that urine output, then you will get confused between 2 and 4. Correct? Shankar Narayana, am I right? Anyone would get confused between option 2 and 4 if you knew it only half the answer. Now you know that hourly urine, every hourly you have to monitor. Okay, that will give you indication whether you will give adequately resuscitating or not. What should be the? Can someone tell me? Unmute and tell me what should be the normal. I'll ask specifically. You don't answer. I'll ask someone randomly. Ananya is there. Ananya, can you please tell us what the normal urine output to tell that fluid resuscitation is adequate?
So it is 0.5 to 1 ml per kg of body weight per hour.
Excellent. In case of electrical burns, keep it on the higher side, 1 to 2 ml. Okay, 2 ml per kg per hour, because you need to flush out all this thing, myoglobin and also. Okay, in electrical injury, it slightly differs. Otherwise, what you have told is right, 0.5 to 1 ml. Good. Okay, next question. Okay. Following metabolic responses to burns occur except Radhika knew the questions all before and only, I think. She is answering even before I would show the questions. Yes, you're all right. Okay, it's simple one, but know the concepts. Okay, for a 4th year level, it's good only. Good question. The answer is D. It should be increased proteolysis, not decreased. Okay, now fasciotomy is indicated in. See, this is yet another type of question where all 4 are right. All 4 options are right. I'll tell you beforehand, but you should select one, the most appropriate one. That's why please go through all the options. This is a learning point. Don't just looking at one option. Don't pick the right answer. Go through the all four and question is, what is your name? First option is Kishan. Second is Kishan Rao. Third is Kishan Rao B. Fourth is Dr. Kishan Rao B. Kishan, I thought, oh, Kishan is my name. I ticked it. But the best answer would be the fourth one. I didn't go till there. That's how I made the mistake. So here the answer is, which one you think? Yes, correct. It is, yeah, flame can also cause S-char. That's right. Everything can cause S-char. Okay. Any deep burns can S-char. But I told you, electrical burns, D. Electrical burns are the most deep and devastating. Mainly includes the muscles. I told you, muscles and bones. So deep they are, and it's usually circumferential. That's the when you need hysterotomy at the most. Okay. In other conditions, okay. Okay. But the most important is electrical burns. Okay, now this is a very tricky one. Read carefully before answering. It seems very silly. All my questions looks very simple and silly, but I'm trying to give some learning points through each question. Okay, see, Azilras is telling thigh, newborn baby. Someone is telling great. Thigh of same person. Excellent. All are with you. I should have done a quiz. Then yes, Radhika is telling B. Why only Radhika is telling differently? Radhika, can you unmute yourself? All are telling D. 99% people are telling D, and only Radhika and Zoom user is telling B. Why? Zoom user, can you unmute yourself?
Sir, I read it in the textbook.
Sorry, you read it in textbook? Anyone can give me the correct explanation? Please, Zoom user. There was some participant called Zoom user who answered as B. Only 2 people gave B, rest all given D. D, I agree. Yes, Zoom, you can't unmute yourself or what? I wanted explanation. Ishan can tell me. Mr. Ishan Sharma, are you there?
Yes, sir.
Yeah, can you tell me? Zoom user telling it's allograft. That's why. What is the question asked here? What is the question? Read carefully.
So allograft is from the same species, na?
Yes.
That means it can be from the cadaver,
Okay.
and autograft is from the same individual.
Yes.
That means all the genetics is all good, all the same.
So autograft is nothing but the same person. Autograft, that's autograft. Allograft is from the different person of the same species. You understood? That's the difference. We just read human skin is taken from allograft, autograft. We didn't go to think. We didn't heed much to that word allograft. What is allograft? It is from the different person of same species. Xenograft means different species. Isograft means identical twin. So there's a difference between autograft and allograft. So it is allograft, not autograft. So thigh of same person is ruled out. Newborn babies, come on, yaar. Who takes from newborn babies? Live donors, okay. Living donors also. No, cadaver, mainly it's taken from the cadavers. First thing, cadavers, okay. We make it into any dead people comes, no. We take out their skin and nowadays we collect them in skin banks. That's how we use allograft, this thing. Live donors who will be ready to donate their that much of skin. It's not a small amount, no. When you require it in a very large amount, it cannot be taken from any living people. Better to take from cadavers. So all 4 looks correct, but third and fourth definitely ruled out. Among first and 2, better option is 2. B is the option. Okay, so you have to. This is just an example I'm giving you. But how can you rule out the possibilities, and how can you give importance to each word in a question? That's what I wanted to stress here. Okay, next question. Okay, this is simple one. Blisters are seen in superficial first degree, superficial second degree, superficial third degree, deep first degree. Yes, the answer is superficial second degree. That's the answer. Okay. That's it. Take just 1 minute water break. Okay, all of you please drink water. And another topic, just 3 topics. I'll quickly finish off. Okay, in 30 minutes or so I'll finish off. Please be with me till then. Skin tumors. Burns and shock for a final year students are 10 markers. These 2 topics, burns and shock. Okay, in shock, that usually hypovolemic or septic shock. These 2 are most probable 10 markers, I'm telling you. Whereas the skin tumors is a most important 5 markers. Any one of them will be definitely asked, either SCC or BCC or melanoma. Any question paper you see, there will be one question on either SCC, BCC or I say melanoma. So you need to know all these 3 in details, because some questions inevitably asked. You can't leave them. Okay. So only there are few topics like that which are repeated in each and every question paper. So it's better to know them in detail. Okay. So the questions asked from this topic are very commonly asked question: enumerate pre-malignant conditions of skin. That's the most commonly asked, repeatedly asked question. Enumerate 5 marker. Enumerate all the pre-malignant conditions of this thing. Okay. Second thing is, particularly they'll specify some malignancy and they'll ask you to in detail the SCC, that's squamous cell carcinoma, basal cell carcinoma, and the third thing is malignant melanoma. We'll see one by one. We know the basics. The epidermis and dermis. Epidermis has got all the 5 layers, that is stratum corneum, stratum lucidum, stratum granulosum, spinosum, basal. Okay. Whereas dermis has got mainly papillary dermis and reticular dermis. Okay. All these things, basics we know already very well. Coming to the classification of skin tumors. This is very important. Okay. Again, they can ask you like classify skin tumors and write about SCC. That will be the usual question asked. Okay, classify and write about any one. So skin tumors can be broadly categorized into epidermal, melanocytic, skin and adnexal tumor, and dermal tumors. So epidermal tumors, then comes in the epidermis only. Next layer is the melanocytes. So melanocytic tumor, and then between the epidermis and dermis, in between there will be other adnexa, skin adnexal components are there. So arising from them, then coming to the deeper dermal layer, arising from the tumor arising from the dermal layer. So they're the dermal tumors. Again, they can be further classified into benign and malignant tumors. So know one example for each. For benign epidermal tumor, the best example would be papilloma, any benign papillomas or warts. Okay. Or seborrheic keratosis. Remember any one, it's enough. Malignant epidermal tumors, that is classical ones, SCC and BCC. These are all epidermal malignant tumors, SCC and BCC. BCC is the most common one, which accounts about 70%, whereas squamous cell carcinoma is the second most common, about 25%. BCC is 1:4 almost, 1:3 or 1:4 is the incidence. For every 4 BCC, 1 SCC you can see. Second heading would be melanocytic tumor. Again, you have benign varieties and malignant. Under benign, you have, very important to know, because these are all the precursors for the major varieties. Junctional nevus, compound nevus, all these are pre-malignant conditions from which it can melanoma can arise. Intradermal nevus, Hutchinson's freckles, multiple freckles, hairy and blue nevus. These are all the benign conditions, but may get transformed into malignancy. Malignant ones are superficial spreading melanoma, nodular melanoma, okay, which is very aggressive one. Superficial spreading is the most common type of malignant melanoma. This is the most aggressive one. Lentigo maligna melanoma, which is the least common. Amelanocytic melanoma, acral lentiginous, desmoplastic melanoma. These are the different types of melanoma which arise from the melanoblasts or melanocytes. Then you have adnexal tumors like benign syringomas, hydradenomas, which we can see over the scalp, sebaceous adenoma. In which condition you get this adenoma sebaceum? Come on. In which condition?
Tuberous sclerosis.
Very good. Tuberous sclerosis. Great. Trichofolliculoma, trichomoniasis, all these are the benign ones. Malignant varieties are hydradenocarcinoma and sebaceous carcinoma. Okay, not very important. Very rare ones, not asked. Dermal tumors again asked, especially for MCQs, neurofibroma, dermatofibroma, and dermatofibroma sarcoma protuberans. All these questions are based on these. To ask, make it simple for you, neuro NF1, NF2. These are for final years, okay? For PG aspirants, and you will be already knowing all these answers. Which chromosome? NF1, neurofibromatosis. Which chromosome is involved? Megazedok, you know about this neurofibromatosis? We have our active member from Africa as well attending the session here. Not 11. 17, yes. 17Q. What about NF2? 22. Perfect. Okay. These are the genes. And what are other what are the other skin features in NF neurofibromatosis? You know, café-au-lait spot, leash nodules. Correct? So that's not the purview of our class here. We are surgeons. Okay. So better to know them. Squamous cell carcinoma. Coming to the second most common variety of skin cancer, that is squamous cell carcinoma. This is a malignant tumor. First, we'll write the introduction, then the risk factors and the etiological factors, clinical features, investigation, treatment. These 5 headings for 5 marker. One line each, you'll get 5 marks full if you write these 5 key words. So in introduction, you should write from which layer this SCC arises from. This arising from the which layer, anyone? Prickle cell layer. That is there in the stratum basalis. Okay, prickle cell layer. Okay, they all arise from the keratinizing cells of the epidermis and its appendages, SCCs. Most commonly from the basal. The basalis, the bottommost layer in the epidermis, that is stratum basalis. In that also prickle cell layer. From there, the SCC arise. That's the first thing you should know. And they express what are the genetic expressions? Cytokeratin 1 and 10. Okay, these two, if you know, it's well and good. This is the second most common skin cancer and common in males. SCC common in males. All these things may not be required, but it arises from the prickle cell layer of the stratum basalis of epidermis. This is the one layer you must write in your answer. Etiology. Coming to the what are the etiological factors? Mainly, the majority of the SCCs arise from because of the ultraviolet exposure, strongly related to the cumulative over a long period of time. When you expose to get the ultraviolet radiation or the sun radiation, that skin will get damaged or mutated, resulting in SCC. That's the most important cause. Second thing, what we see is in the immunosuppressed people. Okay, maybe after so many years, after 10 to 12 or 15 years after organ transplantation, or in AIDS patients or other immunosuppressed patients, we commonly encounter this SCC. Any harmful ionizing radiation can trigger SCC. I told you some HPV wards can further progress to become SCC, like HPV5 and HPV16. Actinic keratosis, this is from or solar keratosis from the sun. Okay, chronic sun exposure can result in solar keratosis or this actinic keratosis that can result in SCC. Some chronic exposure to carcinogens like arsenic or hydrocarbons, coal, tar, etc. What is Bowen's disease? Can anyone tell what is Bowen's disease? You know this. Intra, epidermal.
In situ SCC.
Sorry, who was that?
In situ SCC.
Erythro? Who's that? Parth is answering. Tell me, Parth.
Sir, it is in situ SCC.
Oh, it's not clear, dear. Can anyone else answer? What is Bowen's disease? Yes, that is in situ, correct. Intraepidermal, that is in situ. Okay. If it occurs in glans penis, what is that called? If the same Bowen's disease occur in glans penis, what it's called? Come on. Starts with E. Erythroplasia of, very good. Parth already answered. Okay, that's the, okay. So just to revise them. So any chronic irritation or chronic inflammation like chronic osteomyelitis, chronic burn scars, or any pre-existing very, very unstable scars can go into form SCC. Okay, these are the cancerous conditions or risk factors or etiological factors for SCC. Now, any 4 or 5 important one. One is cumulative exposure, sun exposure. Second thing is, better to know is maybe immunosuppression. Third thing is any chronic irritation or inflammation. Fourth thing, chemical carcinogens. If you know these 3, 4, enough. Okay. In general, not just for SCC, in general, is another important question asked multiple times. Multiple. I'll give you 4 out of 5 stars for this. So important. What are the pre-malignant lesions of skin? I already told you, Bowen's disease, Paget's disease of nipple, leukoderma, solar keratosis, or also another variety, senile keratosis, radiodermatitis, and this chemical arsenic dermatitis, chronic unstable scars develop into Marjolin's ulcer. This itself is a very important question. I'll discuss about this Marjolin's ulcer. Xeroderma pigmentosa. This can lead to all variety of cancers. Again, which what is the defect here in Xeroderma pigmentosa? Can anyone say? Important MCQ. Which chromosome is involved? Xeroderma pigmentosa. Come on. DNA repair, yes, correct. Excision repair defects, correct. Excellent. Purine or pyrimidine? Some nucleotide repair, no? Very good. The gene here is 9q. 9q, okay? Just for your knowledge sake. No, it's not an absolute must to know all these things. Next, any TB of the skin, lupus vulgaris also can lead to any malignancy. These are the pre-malignant conditions, 7, 8. Please know them. Coming to Marjolin's ulcer. Marjolin's ulcer is again 3 marker. Also, it can be kept as a practical station in your like in a short case in your practicals. Marjolin's ulcer is a definition here is it's a well-differentiated squamous cell carcinoma. Occurs in any chronic unstable scars, maybe after burns wounds or maybe chronic venous ulcers or any wounds for that matter, chronic wounds, maybe 15, 20 years. Over that, there develops a very well differentiated SCC. This is called Marjolin's ulcer. As scar is relatively avascular, they grow very, very slow because for any tumor to grow, it requires blood supply, right? But in scar, there is no blood supply at all. So they grow very, very slowly, very slowly. Very slowly. Second thing is, the entire area is damaged. So no nerve supply, no nerves are there. So it's usually painless. No lymphatics in and around. So they don't spread to lymph nodes. So lymphatics, SCC usually spreads by how they spread SCC. Any normal SCC, they spread by lymphatics, right? But this Marjolin's ulcer SCC doesn't spread by lymphatics or blood, no spread at all. It's a locally invasive tumor. But the question here is not this. These are the only for final year students. But the question to any the PG aspirants or any other interns here is when it will spread to the lymph nodes. It won't spread, but when it will spread? That's the question. Hope you understood. 99% of the time it won't spread to lymph nodes. If it goes deeper, yeah, you are right in a way, but in deeper there is no lymphatics. Better answer. You're right. Your thinking is right, but it should be in a broader perspective, not so deep. Jayalakshmi is thinking correctly. Can think better. See the scar. It's not undermined. Here's the scar. This is my limb, for example. See, now we'll make it simple. This is my limb. I have a scar here. And there develops a Marjolin's ulcer. When it will spread to my axillary lymph nodes? That's a simple question. This Marjolin's ulcer. Come on, guys. You can answer it. So, which will see this scar will not have any drainage, any lymphatic drainage, but which has got the lymphatic drainage to axilla is the excellent Jayalakshmi. The adjacent skin, the normal skin, it has got lymphatic drainage, no, to the axilla. So when this Marjolin ulcer comes out of the scar tissue and involves the adjacent skin, normal skin, then the tumor it acts as a normal SCC. Okay, then it will act like a normal SCC and can spread to the region. See, this is how the questions can be made complicated and tricky. For this, it's not given in any books or no teacher will teach you all those things. What you need to know here is analytical skills, just some common sense and some simple analytical skills. If you have, you can answer these kind of questions. So what I would recommend to my juniors there is analyze whatever the scenario is given, whatever the question is given, why it's like this, how it's like this. So put the question there to yourself. You will get the answer out of it. You know everything, but you can't compare or you can't interlink between two things, between medicine and surgery. Why we take the history of diabetes mellitus, or why we take of bronchial asthma in case of hernia? We take in case of hernia, when we take a case of hernia, we ask about history of bronchial asthma. Can even say why? This is how you analyze and interlink between 2-3 subjects. Someone is telling cough, yes, chronic cough, or asthma is not that much of cough. That's more of wheeze and breathing difficulty. So that's ruled out. Jayalakshmi is telling weakening of abdominal muscles. Asthma, no. In asthma, where is increased intra-abdominal pressure? No. Better answer. Come on, think. My intention is to teach you fishing, not to give you fish. So I'll give you some exercise to make your brain work. Inspiratory effort, no. Nothing to related to breathing at all. Nothing to related to the disease per se. During surgery anesthesia, spinal anesthesia we give. It's not for hernia. It doesn't affect in lungs in any way. So we are not worried about a bronchial asthma patient while doing inguinal hernia surgery. Come on, see, last 4 years or 5 years, you have been taking this history. In every case, you asked about history of, in the past history, you asked about the history of diabetes mellitus, hypertension, bronchial asthma, epilepsy, tuberculosis. Yes or no? Yes or no? But you don't know why. No recovery, nothing to do with recovery and all. Simple. What the bronchial asthma patient takes as a medicines usually? What does he or she takes? What is medication for? Yes, corticosteroids. What does corticosteroid do to our body? To the immunity level, immunity or immune levels? Immunosuppression. Excellent. So your body is already, whoever is chronic asthmatic is immunosuppressed state. So whatever the wound you are creating, will it heal? Okay, that's the issue. What are you told? All right, I agree with you. I don't deny that some respiratory problem will be there during the surgery, or chronic cough also can lead to all. Agree, but mainly because of their immunosuppressed state, delayed healing. It results in delayed healing. Last class we discussed, no? What are the systemic factors which result in delayed wound healing? So one of the things is immunosuppression. So that's how. See, what I'm telling you here is giving by example. You should be able to relate like this between two subjects, between two topics, between two things. Then only you can bring out a very good concept. Okay. Hope we'll come back to the topic here. So that's a marginal ulcer for a. So SCC usually appear like a smooth nodular or some verrucous papillomatous or ulcerating lesions. There are three varieties in SCC. One is usually most common one is ulcerative. Second thing is proliferative. Third thing is ulceroproliferative. Ulcerative are the most common, and eventually each and every SCC will ulcerate. Okay, so these are the morphological varieties. And clinically, how do we diagnose to be the SCCs? By this everted edge and indurated skin. Maximum induration is seen in SCC. All the surrounding area becomes hardened. And surroundings area is hardened in the subcutaneous plane. That's called induration. You cannot see, but when you touch, you can see that hardness. That's called induration. Okay. So what about the edges? They're everted, rolled up and everted. It's falling over the normal skin as well. Okay. That's called everted edges. And some amount of inflammation also, in surrounding inflammation also you can see. These are the features of SCC. Microscopically, you must write, SCC asked, you must write one point they're expecting in your answer, that is keratin pearls. Keratin pearls, okay, keratin deposition in the middle, surrounding which there are, see, onion peel like appearance like this, okay. This is called keratin pearls, or epithelial pearls. They stain positive for cytokeratin 1 and 10, I already told you. And depending on this keratin pearls, we have a grading system device that's called Broders grading. To tell the prognosis of the tumor, we use this Broders grading. What is Broders classification is? If the tumor contains more than 75% of the keratin pearls, then it's well differentiated. It's good variety. If it contains 50 to 75% of the keratin pearls, then it's moderately differentiated. If the entire specimen has got 25 to 50% of keratin pearls, poorly differentiated. It's less than very minimum keratin pearls, then it's anaplastic or undifferentiated. Very poor prognosis, very bad prognosis. Okay, that's called Broders classification, depending on the amount of keratin pearls in the specimen. Investigation, any tumors, investigate. These are the very localized tumors without much distant spread or so. You can, any investigation, we write under three headings: blood investigations, radiological investigation, pathological investigation. What are the blood investigations here? You can write any usual blood test, you can write, no specific blood test for SCC. Radiological investigation to look for any spread, like ultrasound of the, for example, for lower limb, you can do the ultrasound of the groin region to look for any inguinal lymphadenopathy. For upper limbs, you can do the like regional lymph nodes, you can check using USG or CT. The confirmatory diagnosis is by biopsy. What is the usual biopsy you do? See, this is the hand. Okay, this is the hand. This is the hand, and there is a SCC here. Okay, this is the we have a SCC. This is the SCC. Okay, which is the everted edges like this, and induration, everything is there. So how do we do the? Can anyone mark the biopsy here? Yes, very good. It's a wedge biopsy. What we take normally here is the wedge biopsy from the edge of the ulceroproliferative lesion. See, we take a biopsy like this. So in a wedge, part of the tumor and part of the normal skin. Why? Why so? Question is why? What type is not important? Why is important? What happens if I take from the center? What if I do the FNAC or some core needle biopsy of the ulcer? Excellent, Sukriti. Very good. Very good. Very good. All are right. Here in the middle lies the necrotic area. Is a necrosis, the part of necrosis, the tumor. So if there is no yield of tumor cells in this, the rapidly dividing cells are present in the periphery or in the side, the edges. Okay, so we want the tumor cells, the rapidly dividing cells we need. That's why we take from the side, the edge of the tumor, and why the normal skin to compare between the normal skin and the tumor. So we take some amount of the tumor and some amount of the normal skin. That's why wedge biopsy in many conditions, any skin conditions, we take usually wedge biopsy to compare, and mainly the proliferating cells are present peripherally. Okay, that's why. Very good. Excellent. So then coming to the treatment. Okay. Treatment is, yeah, any skin tumors, the best treatment would be surgical excision, because these are the very small tumors. You can do excision biopsy also. Instead of doing wedge biopsy, it's a very small tumor, you take out completely and send for biopsy to confirm. Okay, that's called excision biopsy. Or you can do, even once the wedge biopsy is done, the report comes as SCC, then you can do complete excision. That's also possibility. Surgical excision is a treatment of choice. Okay, there are two types of surgical excisions. One is conventionally wide local excision we do. Wide local excision. Okay, if a tumor is less than 2 centimeter in diameter, we do a clearance of 0.5 centimeter. Okay, this is the tumor. Okay, we take it keeping margin of 0.5 centimeter. If the tumor is more than 2 centimeter like this, then we give a margin of around 1 centimeter all around. This is how we do wide local excision. Okay. Now, what happens? Sometimes the tumor may be visible this much only, but some infiltrating here also. Microscopically, it will be present here also. So some tumor will be left behind. So most micrographic surgery or microscopic surgery came into use. Okay, there we utilize microscope for dissection. We take the tumor because these are very superficial tumors only in the epidermis. We take the tumor layer by layer. One small layer we take and send for biopsy. Okay, tumor is present. Next layer we take and send for biopsy. Yes, tumor is present. Next layer we small thin rim we take and send till we get the layer free of tumors. So what happens is, advantage here is only minimal tissue is taken out. Only 0.2 to 0.4 millimeter of clearance is enough. Okay. So, and unnecessary, all the surrounding tissue is not taken out. This is the advantage where you do, when you do the very, very sensitive areas like in face and all, even if a little bit tissue extra also cause a lot of deformity. So in such scenarios, you need to take very minimum crunch of tissue where this most micrographic surgery helps. So that's that can also be asked separately. Many times this BCC question is asked just to know whether you know this most micrographic surgery or not. Okay, one of the, see, behind every question, there will be some intention by the examiner. He will be expecting something out of it. You should know what it is. The main intention of our classes is to tell you that what examiner is expecting you out of that question. What's examiner's intention? It's not given you just because it's an important question or just because it's there in the book. No, his intention of giving a question is whether you know this particular point in that topic or not. Okay, so nowadays this is a recent development, most micrographic surgery, so you should know about that. So especially for BCC, this is employed. So if the question is asked on BCC, you have to mention about this most micrographic surgery, and wide local excision, you know. Other treatment modalities, imiquimod, you know already, toll-like receptor agonist it is, imiquimod that can be used, and 5-fluorouracil can be used, intralesional interferon alpha 2A or 2B can be used. Okay, and radiation therapy. These squamous cell tumors are radiosensitive tumors, so they get disappear just with radiation therapy, so it can be well utilized. Coming to the most common variety of skin tumor, that is BCC, also called, I'll tell one, you should tell another one. Okay, I'll tell the difficult one, that is rodent ulcer, because that I already told Jyotika. Difficult one I already told, rodent ulcer. You tell another name, because how they trick you in the exam, especially entrance exams, is by asking the other names. Okay, we know all about basal cell carcinoma, except that it's also called teardrop cancer. What is the use? In exam, in INACT, they'll ask you which is the most common site of basal cell carcinoma, or teardrop cancer is most commonly seen in. We don't know what is teardrop cancer. Answer, we lost the question. Okay. What is Paupert's ligaments? What is Paupert's ligament? P-O-U-P-A-R-T, Paupert's ligament. Very good, Sukriti. Like this, I can give so many other examples like this. Just asking other names of. That's how entrance exam is difficult from your final exam. In final exam, they'll ask you the common names, the common important question, basic concepts, everything. The same concepts or same topics can be what are made difficult or little complicated by twisting like this, the questions. Hope it's clear now. Where you have to read between the lines, we have to see the what are written on the boxes or in the lower bottom when preparing for entrance exam. That's how, because it's a competitive exam. They need one modality to eliminate. They don't want to select the best. Their aim is to eliminate. Okay, that's why they'll give all these sort of questions. So be prepared for that. BCC, also called rodent ulcer, because it's a locally very aggressive and invasive. It doesn't spread anywhere. It hardly metastasize anywhere, but it's locally destructive type of this thing. So it's called rodent ulcer. It's like a rodent, burrows the underlying tissue. And teardrop cancer or tear cancer, because it's mainly seen in the area of where the tear drops down. In the most commonly it's seen in the line. If you draw from the what is it, tragus to the outer the angle of mouth above this, because this is the most exposed area, the face. In this area, the BCCs are most common. Okay, so this is the most common skin malignancy, accounts for about 75% of all non-melanoma skin cancers. Okay, more common in whites, and male to female preponderance is 3:2. Okay, it's more common in adulthood, especially in elderly. All this SCC, BCC, and all common in elderly patients. Usually, they are very, very slow growing, locally aggressive, locally invasive, and they arise from the basal epidermis and the hair follicles. Okay, pluripotent epithelial cells arising from the basal epidermis and the hair follicles. Okay, BCC. Etiology, same like SCC only. UV radiation exposure and arsenic exposure, coal tar, aromatic hydrocarbons, ionizing radiations, genetic skin cancer, and okay, all this like just like the SCC only, same etiological factors here also. See why it's called teardrop. Clinical features. It's very slow progressive course. Okay, produces very thread-like margins, very thready margin. Sometimes nodule, a small nodule, cystic or nodule in the middle of a lesion, ulcerative lesion, with a central depression or expanding like a rodent. There are two types of growth. Why so many morphological features? Because this BCC spreads by two ways. Initially, it spreads radially. Then later on, it spreads vertically. Okay, in depth. Initially radial, then deeper, or the like upwards, vertical extension. So there are two types of growths for BCC. That's why all these varieties, thread-like margins because of the radial growth, and nodule, that's because of the vertical growth. Okay, so this much this we should know. Mostly occur in head and neck region, the most exposed area. Mucosa is paired. Okay, early BCs are usually small, translucent or pearly white with raised telangiectatic blood vessels. So many. What are the types of edge we get clinically? How do you identify BCC. What is the difference between BCC and SCC clinically? Yes, very good. Very good. In BCC, we get rolled up just above the margin. The edge will be above the margin, whereas in SCC, it will be outside, averted, rolled out margins you see in SCC. It's clinically, okay? And in duration will be maximum in SCC. It's not that much pronounced in case of BCC. Okay. So many variants. In SCC, we had 3 variants, that is ulcerative, proliferative, and ulcer proliferative. Here we have nodular, nodulocystic, cystic, pigmented, and nevoid. Okay, these are the different variants of BCC. And biopsy is the confirmative. Treatment is by, initially you can try medical management for small ones. 5-fluorouracil you can use, or imiquimod you can use. Okay. Best is surgical. Here also, wide local excision you have to do. Wide local excision. And along with that, if it's already spread and all, then you can give radiotherapy. If the underlying fascia, muscles and all involved, then you can give radiotherapy. If it's already spread, it won't spread. But if it's spread, then you may have to give adjuvant chemotherapy as well. Okay. That's about BCC. The main intention of asking BCC is this. Most micrographic surgery. Okay. It offers extremely high cure rates with maximal preservation of the healthy tissue. Okay. So that's the effectiveness of most surgery. Intraoperatively, microscopic examination of the entire surgical margin is done. Once the margin free of tumors is seen or evident, then we can stop the surgery then and there itself. Okay, next coming to the malignant melanoma. So many questions depend on this in entrance exam as well as our final exam. Malignant melanoma, I'll tell you what's the most important thing in this. The first thing is definition. They arise from melanocytes or melanoblasts. What are this function of melanocytes? What is tyrosine 2 dopa 2 melanin. Very good. Excellent. So melanocytes at the epidermal-dermal junction, epidermo-dermal junction, they are present, these melanocytes. So, or melanoblasts, the original cells, from where the cells proliferate to become malignant melanoma. But they may also originate from the mucosa, like oropharynx, nasopharynx, anywhere. Okay. Risk factors. There are some already noticed Fitzpatrick class 1 and 2, that a Fitzpatrick skin lesion high risk, like risk factor classification is there out of the purview here. Sometimes entrance question can be in one of the option, Fitzpatrick class 1, class 2, and some other option will be there. These 2 are high risk for malignant melanoma. And if there is a family history of malignant melanoma or personal previous history of malignant melanoma, history of xeroderma pigmentosa in the patient, okay, all these are risk factor, genetic risk factor, which can predispose for malignant melanoma. Some of the environmental risk factors are intermittent or cumulative sun exposure, or severe blistering sunburn, or long duration exposure to UV radiation. All these are the environmental risk factors for malignant melanoma. Here, what's important is Clark's and Breslow's classifications are there. You should know. Clark's concept says that there are 2 phases of growth in malignant melanoma. Okay. In initial growth phases occur horizontally. Then the later on, the vertical phase occurs with invasion. Okay. And that's it. Yeah, this is the most important. If there is a question on melanoma, means they're expecting this. Okay. This is the one which will distinguish it from BCC, SCC, and all other variety of clinical skin conditions. A, B, C, D, E of melanoma. This will be asked everywhere. everywhere in all the exams. Okay. What is A, B, C, D, E of? This is a diagnostic criteria for malignant melanoma. A, B, C, D, E. A for asymmetry. The border what is that? The outline is asymmetrical. The entire border is not symmetrical on the either sides. It's asymmetrical. The entire margin is irregular. It's not regular. It has not got a particular shape or any pattern. It's very much irregular. I'll show you anyway examples with photos. Then it's not uniform. The color is not uniform. It is highly variable. Some part is some color, other part is different color. So variation of color, variegated colors. Diameter is usually more than 6 mm and continuously evolving. Okay, initially it was small mole, now it has become bigger and color is also different, some irregular. So it is continuously evolving from one phase to another phase. So if these features are there, then it's more likely to be malignant melanoma. So see, these are examples I'll give you. I'll show you this. For example, here is the, I'll show you the photo. Okay, it's not completely visible, this photo here. I'll just draw and show you. Okay, this is one, this is symmetrical. Whereas you have another skin lesion. Like this. This is asymmetrical. The either sides are not ditto each other. It's not mirror image. So asymmetry. This is asymmetry, suggestive of malignant melanoma. Second thing is borders. See, in normal skin conditions, it will be border will be regular like this or well defined. Whereas in a malignant melanoma, it will be like this. It will be irregular. Borders will be irregular. Okay. And the color variation. See, here the color is uniform. But you can see the uniform color is there. Whereas in this condition, see here it's dark. Here is slightly brownish. Here it's very light brownish. So color in the same lesion, color is different. So color variations you can see. Diameter, usually in this other skin, small lesions will be less than 0.5 centimeter. Whereas malignant melanoma will be, to call malignant melanoma, it should be more than 0.6 millimeter. That is the criteria. Okay. Another thing, what you should notice in malignant melanoma is, what you should be aware of is, around the lesion of a skin, normal skin lesion, sometimes, you see, this is the melanoma, supposedly. Around them, you can see small dots like this. These are called, consider this as the earth now. If this is the earth, what are these? Moons. They are the satellites. They are the satellites. So these are called satellite nodules. These are satellite nodules. Where else you get satellite nodules? Can you tell me? Give me another example where you get satellite nodules. See, I always compare and study. When I get some terms or when I get something, I'll compare where else I have heard this, where else I have studied this. So study becomes easy. Yes, very excellent. Carcinoma of breast, we get satellite nodules, skin studdings. Okay. Now, can I ask you another question? Very important. What are the features of skin involvement in carcinoma breast? It's asked in entrance exam also. Very good. Purdy orange. Then 3. One is purdy orange. Next thing is ulceration and fungation. Third thing is satellite nodule. See, my entire topics over there. I have revised everything. When I got a one word satellite nodules, in and around everything is over like that. So if these lesions are within 2 centimeters of the malignant melanoma, then we call it as satellite nodules. If it's more beyond 2 centimeter, if the lesion is here, the nodule is more than the beyond 2 centimeter margin, then we call it as in-transit mets. In-transit metastasis, because these through lymphatics, they are going to the regional lymph nodes. That is where, okay. So that's called in-transit metastasis. Okay, there's a difference. The criteria is less than 2 centimeter and more than 2 centimeter. Remember that. Satellite nodules and in-transit mets. These are the clinical features of where else you, okay, that I'll come to that again. Satellite nodules and in-transit mets. Okay. Most of the melanomas arising from the pre-existing moles. 90% of the melanomas arising from moles, de novo. Okay. So if any mole you have and it is increasing in size or changing its color or anything like that, most probably it could be melanoma. Okay. Now some of the classification, once you diagnose that it has a malignant melanoma, then you have to classify them, and for the prognosis purpose also and for management purpose also. Here I told you there are two classifications, Breslows and Clark's. Breslows classification based on the thickness of the invasion measured by optical micrometer, most important prognostic indicator. Okay. So if it's less than 0.75 mm, level 1, 0.76 to 1.5, it should be sent, okay, 1.5 millimeter, it is level 2, 1.5 mm to 4 mm is 3, it is more than 4 mm, it is level 4. Okay. That's to know the prognosis of the case. Next thing is the Clark's. Clark's is similar, it's better actually. If only epidermis is involved, then it is level 1. If it involves the epidermis and the papillary dermis, it's level 2. Papillary epidermis, papillary dermis, and the reticular dermis, then it's level 3. If it's extending into the subcutaneous tissue also, then it's level 4. This is easy to remember. Remember anyone. Some common varieties of malignant melanoma which can be asked. Superficial. This is mainly for important for your entrance point of view or for MCQs. They'll ask you. There are so many most commons and most important ones in malignant melanoma. I can prepare 100 questions out of this one topic for entrance exam. So important it is. So superficial spreading melanoma, which is the most common presentation, about 70%, usually arising in a pre-existing nevus. I told you, after several years of slow change, followed by rapid growth in the preceding months before presentation. It's spreading. It's a horizontally spreading variety. It's called superficial spreading. Second variety is nodular melanoma. Okay, it is a more aggressive. It is the most aggressive variety of malignant melanoma. It's nodular. Common in mucosa and mucocutaneous junction. Okay, they are usually uniform everywhere and very hard, nodular in consistency, and more of, I told you, if there is a nodules are present, it is having, after radial growth, it is now having vertical growth. Okay, here in this case, the lymph node spread is very common. The prognosis, when they come already, it would have been metastasized. So the prognosis is very poor. Okay, so these are the two varieties. I already told you which is the most very uncommon or rare varieties. Which is the most uncommon variety? Lentigo maligna. Very good. Lentigo maligna. One homework I'll give you today. Okay, please at least so that you will read about that. One homework for you is again very interesting. What is Hutchinson sign? If anyone knows, you can. No, don't tell. Others will not read them. Hutchinson's. You know many Hutchinsons. Now, what is Hutchinson's sign? Particularly Hutchinson's teeth, you know, Hutchinson's triad, you know, many things you know. Now, tell me, please, Hutchinson's sign in malignant melanoma. Okay, that's a homework for you. Please, you can message me or you can post in the group also. Okay, you can individually text me also. Okay, I'll definitely appreciate that if you answer me and if you teach me better. So what are the laboratory or imaging tests you utilize for malignant melanoma? Chest X-ray you can get because it spreads like anything. Malignant melanoma, it spreads to the lungs, giving that cannonball appearance, spreads to the liver, huge hepatomegaly, and PET-CT you can get it done. Okay, and metastatic workup only for T3 and onwards. Not important, that's why I'm skipping. Antibodies you can look for are S100 and HMB45. particular mutations you can look for are BRAF and NRAS mutations. Okay. And treatment, you can give best is surgical treatment, surgical excision. Okay. You also have some monoclonal antibodies nowadays. There will be why I included this not for final years. That's why I'm skipping. I'll anyway give the PPTs. This is mainly for entrance point of view. You have a lot of monoclonal antibodies these days, which acts against the this malignant melanoma. So these can be utilized in many ways very effectively. Okay, targeted therapy, chemotherapy only for very extensive disease which cannot be operated. You can use cisplatin. Okay, is a drug of choice. Dacarbazine is a drug of choice. The other drug is cisplatin. Immunotherapy, you can use interleukin, but you remember only one thing: surgical excision. For final years, that's more than enough. Wide local excision you can have to do. Excision should include all skin and subcutaneous tissue, deep fascia. Okay. Another thing, what you should know in malignant melanoma is sentinel lymph node biopsy. This is the one I told you you must know in malignant melanoma. They're expecting the sentinel lymph node biopsy in case of if they have given the question of malignant melanoma. Where it was first utilized, sentinel lymph node biopsy, and where else we do? Sentinel lymph node biopsy concept first utilized in not breast, first utilized. Yes, Jayalakshmi. It's in penile malignancy, which is the sentinel lymph node there. Name you know. You can unmute also. Yeah, deep inguinal, right? What is the name of that? Lymph node of? If you are from Bangalore and regularly go to parks and all, you will be know. Other than Lal Bagh, you have another park. What is that? Kabban Park. So lymph node of Kabana. Okay. Penile sentinel lymph node of penis. It also used in malignant melanoma. Third thing is nowadays we utilize the same principle for CA breast as well. Okay. Sentinel lymph node. Isosulfan blue is the dye injected near the peritumoral area, and the tumor along with the lymphatics, it will go to the draining regional lymphatics. When you see through a gamma camera, you can see the dye in the sentinel lymph nodes, and you take it out and send for frozen section. If it comes out as positive, then do the entire elective lymph node dissection. Okay. If it is negative, then no need to do the unnecessary lymph node dissection. The concept here or the principle here is this is the first draining lymph node. From that tumor area, sentinel lymph node is the first draining lymph node. If it is negative, then it's unlikely to have any further metastasis. Correct? That's the principle utilized here. The chance of skip lesions directly going from here to the level 2 lymph nodes is 1 or 2%. So for that, why you are doing such a morbid surgery, very big surgery? Okay, that's why. Meanwhile, I want one thought-provoking question for you. Okay, this question today's class is done. Why BCC doesn't spread? Why? I told you BCC never spread. Why? You should have asked me. SCC spreads. Malignant melanoma spreads via blood and all. Why BCC doesn't spread? If anyone tells the answer, I'll immediately send them some gift parcel right now, right today. You don't ask me at this night who will be there and all. Don't ask me. I'll send somehow. If someone answers me this question now, right now. If not, you text me later. Why BCC usually doesn't spread? Usually, I don't say never. Usually doesn't spread via, I'll make it specific, lymphatics. Because very all the face, everywhere there is lymphatics. If there's a tumor in the skin, it should spread, no? Acceleracy is close. but I want a better answer. She's close. Anyway, these are the see what are the important things I'll stress or I'll explain in detail. Sometimes some things I'll skip or I'll sometimes I'll go fast. That's only to tell you that these are theoretical, nothing much to understand or so. Just to see names of the drugs you can't understand. Nothing to understand in the names of the drugs. You have to mug up somehow or you have to revise them repeatedly. So I'm giving my notes or these class PDFs to you anyway. So just before the exam also you go through them. If I keep telling the drugs names and all here, it will take a lot of time. So I'll only tell you the most important things, the points which are required for your exam, and important concepts I'll definitely going to elaborate. Is that okay? It destroys surrounding. No. You are all hypoglycemic now. Your mind is not working at present. So have a proper dinner and think later and answer. First, try to think. Don't straight away Google it. Okay, in Google also you will not get it. First, think on your own. What may be the possible? Then it's a very simple logical. Okay. Same question applies. Similar. If I want to reframe the question, why you get the virtuous lymph node? What is that virtuous lymph node? Virtuous node, no? What is the virtuous node or what is that sign called? I forgot. You remind me now. Supraclavicular. Which is supraclavicular? Someone unmute now. I want to interact. I don't want to see, look at this just chat section. Come on. I want someone to talk to me directly. Dr. D. King. Someone please unmute yourself and answer me. Why there is virtuous node, or what is it sign called, or why it's like that? Why not right supraclavicular? Why only left supraclavicular? We look for. Come on, we have so many students. I want one or two to unmute themselves and answer. Or else I will only.
Because of how the thoracic duct anatomy is.
Tell me, what is anatomy?
I don't know it exactly, but then it is turning to the left side and then draining at an angle into the vein. So it makes it very likely to metastasize there.
No. If it's drain, see, thoracic duct is draining to the IJV. So all the tumors will go into the IJV and go. Why it should go to the coming back to the lymph node there? That's the question. See, you are always fascinated by this sign. That's a Trozier sign, Tauzier sign, virtuous node, virtuous triad, everything. All these fancy names, they interest you. You never think or never thought why it's only left supraclavicular, why not right, or why it comes there to the and segregates in one lymph node. Why, you should think like this. Your orientation should be like that. For both, the answer is same. Why is virtuous node is enlarged, or the why BCC doesn't spread? The answer is same. Oh, better you. Yes, Muhammad Azhar is right. Muhammad Azhar, can you please unmute and tell everyone for the benefit of all the members? Muhammad Azhar is right. We'll not take back anything home. We'll clear it here itself. Otherwise, half of the people will know, half of the people will not try. Azhar, come on.
Sir, it's metastasized into the thoracic duct. Then through the pathway, it enters the angle between left supraclavicular and internal jugular vein. And due to size of the tumor, it can't drain. So due to back pressure, it spills into the adjacent virtuous lymph node.
Very good. Okay. So it will thoracic duct next drains into the capillaries, then it will go to the vein. So size of the tumor is bigger than these capillaries. So it can't pass through. So that will, because of the back pressure, it will come back to the nearby lymph node. Which is the nearby lymph node is left supraclavicular lymph node. Okay, that's why that all the tumor get deposited there. Then it's called virtuous lymph node. The sign or the enlargement of left supraclavicular lymph node is called TRA. See, tumor is O shaped. So Trozier sign. Trauzier sign you get in Migratory thrombophlebitis, where you get 2 Traujo signs are there. One is hypocalcemia, another is pancreatic malignancy, right? That's Traugios, TROU. This is TRO, Traugier sign. Okay, so here also BCC also, the tumor size is very big to enter into the lymphatics or the capillaries. Okay, that's why it doesn't spread. It's okay, simple answer, but no this way. Okay, so any doubts you can ask me, or else it's already time. We already crossed exceeded the time by half an hour. If any questions you can ask. Important topics. Okay, from here onwards we have all the important topics. Next week I have shock, because you have to concentrate more. Any questions? Swati, you can't tell just CA stomach. Okay, it's in all the abdominal visceral malignancies. All the abdominal viscera is drained by thoracic duct. Okay, CA stomach is correct, but in general, it is all the visceral malignancies. Okay, not just stomach. Okay, someone has not understood what is rolled up and what is rolled out margins. Okay, well, in BCC, the edge, the tumors have vertical growth. Okay, so only vertical growth is there. So they pile up on each other and they create a rolled up from this is skin surface. Okay, I'll just draw it for you. This is the skin. Okay, and you have a BCC here, and in the vertical face, see, tumor grow like this vertically. So this is called rolled up from the below surface. The tumor has rolled up, and the how the surface looks like beaded. This is the classical feature of BCC. Whereas in SCC, the proliferation is so fast, okay, so much so that this is outgrows the normal skin proliferation. So they go beyond the normal that skin what that ulcer margin. They go beyond the cells. Proliferated cells will go beyond the ulcer margin to encroach the normal skin also. This is called everted or rolled out margins. Everted or rolled out margins. Okay, I want to, okay, if you are okay, please write along with me one important chart telling the difference of all the three. In one chart, we will write. Is it okay? This is the one chart. We will all write together. Come. This is a summary of entire thing. This is summary. Okay, we'll just revise all the three tumors in one chart. The incidence wise, which is the most common one, this is the today's quiz. Quiz is all based on the questions, all based on this one particular chart. So incidence wise, which is the most important, highest incidence of skin tumor is BCC. The most common one is BCC, correct? About 60 to 70%. Second most common is squamous cell carcinoma, 20 to 30%. The least common is malignant melanoma. That's the first question, the incidence. Second thing is from which layer, the answer also while writing, we write the first line as from which layer they arise. So SCC arising from the prickle cell layer of the stratum basalis, whereas BCC again from the basal layer only. Okay, malignant melanoma from the melanoblast or melanophores. Okay, etiology almost same. All three skin cancers arise because of the chronic irritation of the skin, because of the UV rays or some genetic predispositions or some whereas malignant melanoma most of the times because of the pre-existing moles, moles, pre-existing moles, congenital moles, okay, or sometimes de novo it can arise. Fourth thing, site. SCC is more common in trunk, leg, hand, oral cavity, whereas BCC is in the, I told you, in the face, more common in the face, that too, the above this line. Whereas malignant melanoma, this percentage is also very important. It's asked many times questions. 25% common in head and neck, 25% in the trunk, 25% in the lower limbs. Okay, so the 25% most common in head and neck, 25%, and 25% incidence in the trunk, and 25% in the lower limbs. Remember like that. Types: ulcerative, proliferative, ulceroproliferative, SCC. Whereas in BCC, you have nodular, nodulocystic, noduloproliferative, etc. In malignant melanoma, you have mainly superficial spreading type and nodular variety and lentigo maligna, acral variety, A melanotic, all those things. Edges, clinically, how do you distinguish by edges? In SCC, we have everted edges. In BCC, we have rolled up and beaded edges. In malignant melanoma, we have irregular edges or margins. Induration of the hardness of the subcutaneous tissue is maximum in the SCC because it's spreading. BCC, it's moderate, whereas in malignant melanoma, you don't find any kind of induration. Scab. Remember, my dear friends, scab formation is a feature of benign skin lesions. Scab, if there is anywhere is a scab, just like a black dot, scab formation is there. It's a benign skin condition. Only malignant condition where you see scab formation is BCC. BCC is the only condition you get. Only malignant condition where you get scab formation. See, these are all the how the questions can be prepared. You understood now? From one point, you can prepare a question. Pigmentation is absent in BCC and SCC in 90% of, because they arise from the melanocytes. Pigmentation is present in the malignant melanoma. Spread SCC mainly by lymphatics. Okay, whereas basal cell BCC doesn't spread. Malignant melanoma spread by mainly by lymphatics and also by bloodstream. Okay. Cytokeratins, I told expressions. SCC, you remember which are those cytokeratins which expressed by SCC? Very good. Sukriti, excellent. 1 and 10. See, that's why each point is important. When we teach something, we keep in mind what are the previously asked questions, what are the important, what can be made into question. Keeping that in mind, we teach. So give attention for everything. No unnecessary, unwanted things will be discussed in the class. Thank you so much. With this, we conclude. If no other doubts, let's call it a day. Thank you so much. It was a very exhaustive class, 2.5 hours. Even I don't want to prolong that much, but I see a lot of enthusiastic students here. Many from abroad, other countries also, and many PG aspirants are here. Many third years are there. So when so many interested students are there, I assume that you people are ready. You come prepared. Okay, you want to learn more and better. That's why we discuss everything in detail, and so much for time is not a constraint for us. Thank you so much for such a lovely interaction. You all answered really well. Brilliant. Brilliant answers. You need to make your concepts a little more better. That's it. Otherwise, you're doing really well. Next class, at another important topic, let's discuss. Till then, keep revising. Happy studies. Thank you so much.